here we go. So I have a current research project with Nevro. I've used a bunch of different systems. Those 4 are the ones that are approved at University of Washington. I've used those. I think SCS, when used appropriately, can be life-changing and fantastic for our patients. The other thing to know is that with a lot of things we think about implanting, it's hard to know which device will serve the patient best, because there are so many different mechanisms of actions, there's so many details, you cannot know the patient's physiology. And it's 2019, we don't really know how spinal cord stimulation works. We really don't. I have a lot of friends who hang out in labs and work on mice and rats and things like that and stimulate them and look at things. We don't know how it works. Melzack and Wall had an interesting idea. That was a long time ago. And we've changed things a lot since then. We really don't know how it works. So if you don't know how it works, and there's a bunch of different things that will do different things, you don't know what's the best. I have been trained in DRG stimulation, but in the state of Washington, how many of you live or practice in the state of Washington? Getting stimulation approved here is super challenging, like 50 out of the 50 states, like 50th for getting approved. So it's really challenging. DRG is extra challenging in this state. So it's been hard to make it happen. So the goals for spinal cord stimulation are to see if SCS is a good option for your patient, an implant, and determine where to put the permanent contacts, and to decide how you're going to get that. If you decide that stimulation is good for your patient, how are you going to put it in? Are you going to do it with you doing it, or are you going to send it off to a surgeon? And every patient requires something a little bit different. And over time, things change. In the past, when we were doing paresthesia-dependent things, this tripole approach was my favorite thing. So I put tripoles in all the time, because I thought you could cover the back really better with this. And for traditional stimulation, there's all kinds of modeling that shows you can get the stimulation in deeper and have more options with this. I don't do tripoles anymore because we've moved beyond this, but there's some interesting slides of that. So if you look at the literature, what counts as a successful trial? Well, one version of a successful trial is you have greater than 50% pain relief. Another version of success is more than that, and I would never accept just 50%. So I think they need to have much more than 50% pain relief and improved function, and they need to be able to look me in the eye and say, this is the best thing I've tried for my pain control. If they can't do that, then why spend that much money, put them through surgery, et cetera? It's got to be the best thing that they've done, and it has to be something that's going to make a difference in their lives. So you get that return on investment over the next 2 to 10 or 15 years. There's good evidence that if the patient has less than 50% pain relief, then they are unlikely to have sustained long-term benefit. I work at a university setting. If you work at a university setting, what kind of things do you see? Well, you see some things from our local little university health community. We also see things that come from other providers, other places that haven't gone well. So I will be honest, most of the spinal cord stimulators I see were not placed by me. If they're coming to see me, that means that they're not happy with it, right? So what are some of the factors people think are associated with it not working so well? Any ideas? So there's 2 big things, or 3 things, I'd say. One thing is psychological issues that were ignored. Anxiety, depression, catastrophizing, poor coping, et cetera. Second is the patient has widespread pain, but they chose to talk about their back pain with their provider or their leg pain, and they ignore the rest of their pains, which are equally debilitating to them and impact their quality of life just as much. And third thing is just wishful thinking during the trial, where the patient really, really, really wanted it to work and really, really, really said, okay, I need to say it's 50%, so I'll say it's 50%, so I get it, it's going to really, really, really work. A lot of people really do that, unfortunately. So when you think about the trials, there's a lot of variation, and you want yours to be successful as much as you can. So you want the challenges to come from the patient, not from your skill set. You want to have good skills that you can apply to each patient in each situation, and think about it and plan. So I did a spinal cord stimulation trial in this patient, and I had to really think about how I was going to get in there and where I was going to put the leads. And when we do trials, we usually use 1 to 2 leads. With traditional stimulation, the goal is to provide some sort of stimulation over the painful area. For high-frequency stimulation, it's typically T9 to T11. When peripheral neuropathy was first being looked at, we often talked about placing one lead a little bit lower. I see lots of peripheral neuropathy patients because neuropathic pain is kind of a thing I do. So I sometimes you'll see some of these HF10 slides with the lead a little bit low. I sometimes use more than 2 leads in certain situations, which I'll show you. When I was first taught to do spinal cord stimulation implants, we used an implanted anchored lead with a temporary extension, which was clearly associated with increased risk of infection, and also necessitated a second visit to the operating room. And also patients say, well, I've already been through one operation, you're gonna go through a second one anyway, might as well just put the device in. So a lot of people seem like had a less good outcome with that. So I don't do that anymore. I think most people use temporary leads most of the time. So during the trial, once you have the leads in place, you want them to stay wherever you've just spent a lot of time and effort putting them. So I limit bending, lifting, twisting, BLT. I have the patient try multiple different programs, no matter what vendor we're using. The trial duration can be really quite varied. A few times recently, I've been having patients start with one company and have a planned switch to another company later on, so they can try 2 very different things. When you think about that, there's some logistics you have to plan for that. And then think about the judging for how you're gonna go forward with something else. Like I said, you can the leads are compatible with each other, so you can switch. You can start with whatever company you want to start with first. Unless the patient says it's an absolute 100% home run, it's the best thing in my life, then you can always switch and try something with a different mechanism of action. And it's a good chance your patient will really only have one trial. So if you screw it up, if you don't give it the best effort, then they are going to be denied this potentially really life-altering good therapy. So you want to do the best job possible to make sure that they get the best outcome possible. So it's your big chance. These are the NAC guidelines, which are detailed and all completely reasonable. So the first one is you should be trained. A good thing you're here in a fellowship. And then you understand how to manage complications. You do them in operating room and sterile environments, neuropathic pain conditions before using opioids is a suggestion. That is not widely adopted by the community. It is adopted, of course, by people who put stimulators in, and it's not an unreasonable thing to think about. That patients have had failed reasonable treatment beforehand, and that you think about how you select your patients carefully, that you have an evaluation in advance by a psychologist, and then you honor the patient's wishes about things. You don't say, I always use this, therefore I'm always going to use it on you. You have to really honor the patient's input about this. And that you should understand, you should explain things to your patient in a meaningful and good way. So one way of doing that is having the patient tell it back to you and explain back to you what they think you think, what they think you're planning on doing to them and what benefit they're going to have from that. And it keeps on going. So you need to discuss the plans like we just talked about, and then have a checklist to make sure you're ready to go. Like, here's the things we need to do before we do this. You have a trial for tolerability, which is what we're talking about today, that should be evaluated for risk of anticoagulation. I'm sure that many of the faculty have done some medical legal work, and some of us have had the opportunity of seeing some really bad outcomes with spinal cord stimulation. This is an area where it's not infrequent for there to be a problem. And guidelines for anticoagulation have changed from a decade ago. Aspirin, we don't care so much about that. We care about that a lot now because there's been several case reports of things. So pay attention to current guidelines for anticoagulation. Use a sterile environment like we just talked about, using meticulous sterile techniques. Ideal anesthesia strategy enables real-time interaction between implanter and patient. So that means sedation or MAC anesthesia. Antibiotics are important because you don't want infection, another big bugaboo. And that you should not just implant and say goodbye or put the trial leads and say goodbye. You need to interact with the patient before and after. And that programming is complicated. And programming needs to be done meticulously and frequently. And then you have a quality control system in place. So these are pretty reasonable things. So my version of that is, before you start, make sure you're going to be able to cover most of the area of the pain, or else how can you possibly have 50% pain relief? So you need to cover the big area. You need to make sure you do the psychology evaluation like we talked about and NAC suggests. You need to identify and treat remote infections. You need to think about coagulation status, give antibiotics, and then carefully think about positioning, surgical scrub, and sterile technique. Those are really, really important to minimize your complications. Then needle entry. We all know you want some type of shallow paramedian. You don't want to go with the epidural space like this. You will puncture the dura before you can make that 90-degree turn. You come in a nice shallow angle. As was pointed out in the last talk, if you get into the epidural space for a trial any old way, and you're really good at steering, you've got a needle you can direct, you can often get the lead where you want to. That won't work for the permanent implant, and your success rate will be lower. So the closer you are to midline when you find loss, the better it's going to be. And the closer you are to that spinous process, the better it's going to be for anchoring, et cetera, in the future. So practice doing good things is going to work really well. Remember, body habitus really, really matters. As was pointed out also in the last lecture, if they have a BMI of 40, you're going to start a lot further away from the target or accept a steeper angle than if they have a BMI of 19. Quite different. And then you advance. I use saline for loss of resistance. The only comparative studies between saline and air show that saline is a superior technique to air. But look for loss of resistance. If you're not sure, check, check, check. You can check with radiographic. You can try advancing the lead or a lead blank and see if you're there. And then if you have difficulty, problem solve. Here's one way to do a lot of problem solving. It wasn't so easy. So either you can use the same entry point and just change where you're trying to enter the epidural space in that same space. You can, if they're thin, you can go up to the space above. You can use the curved needle to kind of direct it differently. You can do a lot of things without actually pulling the needle back out of the patient. Don't spend too much time doing that if you're not having any success, but quickly explore other options and then move on to a different level. Think about it. Or try a different path, do something different. Often, starting afresh helps you get to the target you want to get to. And then you advance it up. I think it's a good practice not to show your hands on the x-ray. I am shocked how often I see this. Like, okay, that's really nice. You have a little early arthritis going on in your DIP, but really you don't want to see your hands. Nor do you want to have that beam going all over the place for everybody in the room or the patient. So columnate, think about where your hands are. Once you have the needle in place, shift up so only the very bottom of the needle is showing up as you advance the lead. So think about that. Advance under pulsed or live fluoro only. Don't advance without knowing what you're doing. And use most implanters use the hand closest to do the advancing and the one posterior to do more of the steering. Sometimes you have to use two hands if it's difficult, but usually that's the primary way of doing it. Only advance if it's headed where you want it to be. This is like a key thing. A lot of times people think, well, I'm going a little to the right, but I'll just aim back to the left and I'll get there. But then you end up with the lead doing this. Who wants that? Not me. Neither does your patient, neither do you. You want to go up. If it's not going up, then pull back and redirect. Do not let yourself get off into the gutter or accidentally anterior. So that's what I mean. A straight path is the best path. If you're having difficulty, you can change stylettes. And if you've really, really exhausted things, take what you can get. And sometimes taking what you can get, especially with newer stimulation patterns, is good enough. And also know where you're headed before you start. So most of the time, we know where we need to be. We talked about anatomic placement rather than using stimulation to guide us. You know where you're going to be most of the time. That isn't always true, but most of the time you are. So typically I put two leads in. You want redundancy at the sweetest of the spots so that if one lead moves, you're covered and there's options for programming the patient. So with traditional stimulation, or as is called now tonic stimulation, which I promise was not developed by the people who developed traditional stimulation, that term tonic stimulation, it's essentially have stimulation covering the area of the pain. So you need to reposition the leads until you get that. In the room, I don't care if the patient has pain relief. Not one bit. The goal is to put the leads where they're supposed to be. And if you're going to use traditional stimulation as part of what you're doing or as an option, you need to, and you want to check paresthesias, you need to kind of cover the area. I mentioned the importance of redundancy. The other thing is that if your absolute best coverage is the top 2 contacts, not so good, because during trials, sometimes leads pull down. If they don't really advance much. So you need to think about where you are and make your target in the middle or the bottom of your contact, so if the leads move down a little bit, you're still have good coverage. So this is a patient that had 2 distinct and separate pain problems. He had persistent pain following spine surgery, which is my preferred technique preferred terminology for failed back surgery syndrome. And he also had diabetic peripheral neuropathy. So I put 2 leads in initially. No matter what I did, I couldn't cover both areas with the traditional stimulation. So I advanced the leads up for his back a little higher, put in 2 other leads down for his feet. I couldn't get both feet with 1 lead. I had to put 2 leads in, so I ended up with a 4-lead trial, not the usual thing. So when you do a trial, you can get an idea how things are going to go pretty early. If the patient tells you that the skin wheel was really problematic and they didn't like the positioning and they're really, really super finicky, they may be super finicky from there on out. So they may be finicky with everything you do to them. So just bear that in mind. If it's a really specific, you're trying to get traditional stimulation, there's only one little tiny spot you get traditional stimulation, that may not be a good, successful long-term strategy for the patient. I've had plenty of those patients convert to a paresthesia-free approach that have worked fine. But that may mean that's not a good future for paresthesia-based stimulation. If you put the lead in everywhere it's covering the target, that can be a very nice sign. Then you need to secure the leads. You want them to stay put during the trial. You want to carefully remove the needles and stylettes while watching. So if you've seen the movie Shrek, Shrek's mom tells him it's better out than in, referring to gas. Well, for leads, when you're taking the needle out, better to put it in a little further and then pull it back. Because you don't want to pull the lead out with the needle. That's really embarrassing and feels stupid. Don't do that. You can advance a little bit. You can always pull back after you're in. I use a stay fix dressing. There's different techniques. Some people secure with the suture. There's not good data that says that's better. There's one study that shows it was less good to do that. I take the final images after the lead is secured, so I really know where it is as the trial is starting. If you've looked at some other people's trials, it can be really, really frustrating to look at the images they save, because sometimes they don't have any reference point. You just say, yep, there's 2 leads in the spine someplace. So I always try to include a reference point. The reference point is L1. L1 looks different from T12. Because guess what? T12, T11, T10, T9 on a close-in X-ray don't look that different. On a kind of poor resolution image from the OR. So I always include L1. And I have this habit of putting a needle across the T12, L1 interspace, so I know that's T12, L1. So I know where I am, I know where those leads are. And it can also assist with programming. Then I have the patients try a whole bunch of trials. They stay in touch, they call for problems. You make sure that they take care of the leads and understand this is a big deal. I had a patient last year who came from a different part of the state, was staying at a really, really inexpensive VRBO, which there's a reason it was inexpensive. And we put the trial leads in. A day and a half in, he tumbles down the horrible steps in front of the place and pulls one lead completely out, and the other one's way, way down. So we had to start all over. Remember to give them instructions about not bending, lifting, and twisting. And after that first day, make them do things. What usually makes your pain worse? As long as it's not, bending, doing something like this, they can do a lot of things and test it out and see what it's like. I don't give opioids for discomfort, and then we judge how things are going. So this is an image, which no one would ever place leads like this. So those are wide space leads down low. So this is a salvage attempt. This is someone who had a trial with paresthesia-free system, had 0 pain relief. Every little trick pulled out of the bag, nothing worked. So we pulled the leads down so we could get some type of paresthesia in the area of the pain, which was a peripheral neuropathy. And try to proceed with the trial from there. When you go from one technology to another technology, sometimes you need to change where the lead is. And again, you can always pull out. You can't really advance in a sterile fashion once you've secured the leads. So if you have them a little high to start with, that's fine, because you can always pull down to switch and do something different. If the patient tells you, quote, it helps, and the relief is not super dramatic, are you stimulating where you think you are? Do you, especially if you have a paresthesia-free system, if the lead's moved and no one knows it, so you might think about re-imaging. You might try a different system like we just talked about, and then discuss with the patient, or have whoever sees your patients for follow-up discuss with the patient what's different since you did it, what were they expecting to happen, what's happened, what really has happened, and sort it out, and see if there's anything else we can do. If it's nice, dramatic pain relief, then you think about moving forward, and I start talking about the next step right away. Why delay talking about that? And when you start talking and planning for the next step means a couple of things. One is if you spent a long time getting in and you felt like, oh my God, I'm so lucky I finally got it in. Do you want to do that in the operating room after you made an incision? I don't know. So you might send that person off for a percutaneous lead. If you feel like this was routine, ready to go, then and you're an implanter, then go forward with doing it. And I go ahead and discuss the risks of permanent implant, decide what to do. So these are all very different looking trials. That one on the far right obviously had a previous system in place that was targeted only for the foot. And it worked okay for the foot, but that wasn't where her main pain was. Her main pain was higher, so we put leads up above, and then that worked much better. So you need to kind of think about what you're going to do and then discuss how you're going to proceed. And I kind of go through all the things. I talk about long-term complications, et cetera. When we get to the implant, we'll talk more about this. And also remember, kind of like I said at the beginning, if it doesn't go like you want to, you need to think about what you're going to do. So try lower, try higher, try more to the left, try to the right, try a different needle, change stylettes. Be reasonably persistent. You don't want to screw your whole schedule and whole day and put your patient through unnecessary torture all day long, but be persistent. Try to get it in. If you can't find the midline, think about it. I mean, these are things that people have happen. So for wet tap, how many of you have had a wet tap doing a stimulator trial? Raise your hand, come on. Yes, what'd you do? That's a good answer. Totally reasonable answer. I wouldn't really try the same level again, but I'm happy to go on to another level. Okay. I've had medical events. I've had patients say really early on, you know, this is too uncomfortable for me, despite the fact that they're not really breathing very well because they're so sedated. That doesn't happen very often, but when it does, time to stop and pull out. It's better to stop and not complete a trial that's not going to be successful and then regroup and think what you're going to do, then press forward just so you get finished. I've also had equipment problems. So all of those things can happen. The more you do, the more you're going to run into. You need to think about what you're going to do when you encounter those difficulties. So we have a few minutes to talk about trial stuff. I covered a bunch of stuff really fast. I'm happy to answer any question before we move on. Yes?
So when you're doing a multi-vendor trial, you walk through kind of what leads would you start with and kind of like how that process works?
So if you think about, let's say, the Nevro leads, they are wider space than everybody else, and they have a specific location they need to be in. And with being wider space, they're not optimized for a paresthesia-based system. So I tend to go to Nevro and start with something else. And if you use a 16-contact Boston Scientific lead, for instance, and you hook up to a Nevro system, they cannot stimulate the bottom 8 contacts, only the top 8. So let's say I'm doing that. Say I do 2 16s, and I'm going to go to Nevro. I plan how many days? 5 days. I say, you guys have 5 days, and then we're switching over. On that 5th day, make sure I have access to a fluoro machine. I have the Nevro rep come in, look at the images, and say, we need these contacts here or there for us. We walk into the fluoro suite, take the dressing off, under live fluoro, pull it down, redress, and they're off for the Nevro trial. That's how I've been doing this. I've had to be successful for visceral pain and for other things. Like one of the visceral pain patients had 0 relief despite perfect stimulation coverage, and then we switched to Nevro, worked fine.
So is it 5 days for each? And then Are you?
Ish, maybe a little longer, Kind of, it's a little variable.
And are they getting oral antibiotics?
No. I give antibiotics the time of insertion for a trial, and I'll give oral antibiotics for a trial. I've never had an infection on a trial lead beyond a superficial at the site. Those are good logistical questions. Any other questions about trialing? Yes.
Just to comment, right, I do 224. Start off with Medtronic and Boston, 2 days each, and then I do 4 days with Nevro. Nevro requires high frequency, requires the neuro combination of the so-called wash-in. It takes longer to do that. Just remember that if you're going to do high frequency, HF10, it takes a little while and the patient gets to it. And that's right, the leads can be used. I start off with either Boston or Medtronic. You just use those throughout.
Excellent. Any other questions or comments? I can see you have one.
Yeah,
Go ahead.
Sorry. So the images you take at the end are, I'm assuming, are you having to stand up and take a...
No, they're just on the table. I'm not going to do extra hassle stuff. I just do them right there on the table. I get a lateral too. I always get a lateral at some point. If you've threaded the lead straight up the midline, I don't understand why you need to check a lateral before you do stimulate, unless you're doing a non-stimulation system. If you're doing a non-stimulation system, of course you can check a lateral before you do anything else. But if you're doing stimulation, you'll know pretty quickly if it's anterior. Yes?
With the new Nevro IPG taking jurisdiction, do you find that you'll still do the multi-vendor switching? Or?
So the question is about the new Nevro Omnia IPG. So their old IPG could do traditional stimulation too. It just couldn't combine it with other things. So that is not as new as it may sound like it is. But their contacts are not idealized for doing traditional stimulation. And I've been doing stimulation for a long time. And there's a big thing in the past about, we want to cover a lot of areas, so we're going to have this quad plus lead that covers multiple areas where the contacts are really far apart. And you realize you couldn't really steer and refine the stimulation very much. And so steering and refining the stimulation involves tight spacing and possibly 2 or 3 side by side. And it just isn't set up for that. You could do that, and it would be a totally reasonable thing to have that be your practice. I just don't think it's a true trial of what the other option is. But that's my opinion. Other people can have different opinion, and there's other people in the room that do stimulation. So ask everybody else that question too.